for everyone who's ever been told that their blood tests are completely normal, that all of it looks fine, but they're still feeling really exhausted and inflamed and anxious.
People have been supplementing with their iron with their breakfast and their coffee every morning. And so we know that coffee blocks the absorption of iron.
Do you have any idea where those reference ranges came from?
No. Do you?
This episode is for everyone who's ever been told that their blood tests are completely normal, that there's nothing wrong, that all of it looks fine, but they're still feeling really exhausted and inflamed and anxious, and they're struggling to possibly conceive, and they're just not feeling like themselves. The thing about pathology is, what we know is that result is not the patient.
No. And we also know that optimal is different to not super deficient.
Absolutely. So then what does normal mean? Like, what does that actually mean? What are we saying is normal? Or what are our doctors saying is normal when they're looking at all of the pathology?
Yeah, so the reference ranges that doctors use is when they're talking about where do you become like a disease pathology of being very deficient. Now that is very different to somewhere where you're at an optimal health.
Yeah.
And we want you to be at that optimal health range. But I think like as naturopaths, the big thing for us is connecting the person in front of us with the pathology.
Yeah. Well, no one person is a pile of paper.
No.
And, over the years I've seen so many patients come with those big files where they've got, all of that information, which is beautiful to gather it all, but no one's really just sat down, put that paper down, put all those files down and looked at them and said, what's going on? Like,
How are you feeling?
How are you feeling?
Yeah.
And I think there's probably three things here. There's like disease detection, there's optimal, and then there's also this word normal.
Yes.
So we are looking to get people, for us in clinic, beyond normal, right? Into this wonderful unicorn world of optimization. That is our goal.
Yes.
Normal's okay sometimes.
And I think as well, when it comes to normal, right, I always bring it back to the person in front of us. So if I have someone sitting in front of me and they're normal, they're healthy, they're not trying to conceive, but it's just a general check-in, and I have a look at their bloods and it's not in that optimal range that we're talking about, but you're fine. I'm not potentially thinking we need to go down all these rabbit holes with you.
Yeah.
But if I have someone sitting in front of me that is exhausted, you've got bad brain fog, you can barely get out of bed, you're not sleeping, all these weird symptoms, and then I see all these different reference ranges that you're sitting at that aren't in our optimal range, well, then that's a red flag.
Yeah.
And these are simple things that we can start to improve.
Easy fix to at least begin, and then, hopefully it will help them, make them feel better. And that gives us clarity with where we go next as well. Because some of the most frustrating, patient stories are everything comes back normal. I'm not sick. Well, that's great. We don't want you to be sick. We don't want you to have, we're checking for, when I'm run through, like say it would not be abnormal for me to get 42 pages of pathology. And I'll go, okay. And then I just start scrolling and I'm looking to make sure that they don't have insulin resistance, that there's not diabetes markers, that they don't have, cardiovascular markers and not thyroid disease. I want to make sure all that's good.
Yeah.
And I can get to the bottom and have found not one remarkable thing. Their vitamin D might be within range, and vitamin D is a good one to talk about range versus optimal, because that is quite the different. That might be a good place to start. Do you want to do vitamin D?
Yeah, look, I think vitamin D is so interesting because vitamin D is really important not only for your immune system, but it's also really important for your bone health. It's a hormone, right? It's not a vitamin. And we need to stop thinking it's just a vitamin. And look, whilst I love that everybody is anti-aging and with the sunscreen, and that's fantastic, we're also indoors more and no one's getting the vitamin D exposure that we used to. Back in the day, what should happen is we get this beautiful sun exposure during summer. It tops us up because we do store it. And then gradually during winter, it will slowly decline before we then top it back up again. But like I know coming into winter, I am on all of my clients to check their vitamin D levels because you're not getting any more sun. So I want to make sure you're doing really well. But then also, if you have darker skin, if you're Muslim and you're covered, I saw a man the other day and it was for fertility, and I love that I saw markers for a man because that's so often we don't see male pathology. And then I looked and I was like, oh my gosh, your vitamin D is terrible. And he was like, and his partner, I should say, his wife said, well, he's a worker and wears thick protective clothes all day, so he never sees the sun. And so for these people, you have this limitation with the amount that you'll get. And so it does mean that you probably will have to supplement.
Even the sunglasses, because vitamin D has this special kind of thing it does in the eyes.
Yeah.
But also some people can't convert it.
Yes.
You know, so they might get sun exposure and then it's not enough. And it's very specific too, like that 15-minute window on long limbs.
Yeah.
Outside of midday time twice. Like it's quite specific. So if you work a 9 to 5,
I know,
especially during winter.
Absolutely.
So that, I think what you're, alluding to is context, really. The context really matters. So the vitamin D in summer being, say, at, 50 for somebody who just wants to be healthy and happy, maybe it's 60 or 70. Fine, great, good. Going to the beach once a week, they're doing whatever.
Yeah.
But the vitamin D during winter at that same amount for someone trying to conceive is not enough.
Yeah. And the vitamin D that we want for someone trying to conceive is considerably higher.
It is.
We do like it to be up around 100.
I like it over 100.
Yeah.
Yeah.
But if we can, sometimes it's even just a battle to get it there.
Absolutely.
So if we can get you as close to 100 as possible, it's great.
Yeah.
But, again, I see so many people coming through the clinic and okay, this is also coming back to blood tests, right? Is the amount of times I've looked at blood tests and I see giant red flags in multiple areas. And I'm always like, did your doctor talk to you about anything in this blood test?
I always ask that. So have they spoken to you at all?
And they're like, no, they said everything's fine. And I'm like, you're not fine. And they're like, I know, I'm not fine.
Yeah, well, they're not feeling fine. That's why they probably went and got the blood tests. Not saying anything,
Absolutely.
But we have different ways of looking at it.
Yeah.
We want people to be not just disease-free. That's the bare minimum. Great. You don't have any of those markers that are serious disease markers.
Yeah.
That's fantastic. We're so happy for you. But there's still information here that we can use. We are going to link it back to that person. We're going to link it back to their symptoms, their history, all of those things, the context, always.
Yeah.
But it can be, really valuable information even if the GP didn't see it that way at that time based on what you went in for.
Yeah, absolutely. And I think another really good example of this is iron.
Iron is really important. We're always talking about iron.
Yeah. And I mean, especially for bleeding women, right? Like if you are someone that has consistent heavy bleeding, first of all, come and see us. That's what we can help you with. But we got to check your iron.
Yeah.
It's really important. I have one of my women who is perimenopausal now, and she's been getting flooding bleeding, which we're trying to address. But she had traditionally had horrible iron. And obviously the poor thing is bleeding so much, right?
Yeah.
Of course she's going to. But what was really interesting is when she recently had an episode of really heavy bleeding and she got her bloods done, her iron is okay. And I was like, oh, I'm so glad because we've been doing the hard work with her iron supplement to really try and hold on to that iron.
Iron's a really good one, to talk about the fact that there's more than one thing we want tested there. So vitamin D, you test the vitamin D, it says something weird like OH, whatever. We know that's vitamin D, that's it, said, done, by. Iron, we don't just look at the ferritin. A lot of the time I'm getting the blood test and it's just the ferritin. And I understand that, there's costs involved in a full iron panel beyond that. Put that aside, we really need to see what that iron's doing in the body. So the thing about iron is we can test how it's being stored. We can test how the taxis or the Ubers are moving it around the body, the transporters. And we want to look at that in combination with something like a hemoglobin. I want to see how the oxygen's moving around as well.
Do you want to explain which of those are each of those different markers?
Yes. Iron is iron.
Yeah.
That's your first one.
Yeah.
Ferritin's your storage. Transferrin, keeping in mind, everybody, I'm not a doctor. Transferrin is one of your Ubers, your taxis moving around. Then we've got the saturation, so the amount of iron that it's not in storage, it's available and it's ready to go in the blood. It's a saturation that is in the red blood cells.
Yeah.
Hemoglobin is the oxygen
Yeah.
carrier. So, for me, my iron was chronically low. I had a ferritin of 2. I could never store it. I could get my transporters up. Great. It was when my hemoglobin started dropping that becomes a really serious health concern.
Yeah.
So there's not enough oxygen getting to your brain and your other vital organs. I feel like I'm forgetting one.
No, I think that's all of
Is
them.
that all of them? I feel like there's another one. But that gives us a basic idea of, you know, what that panel should be telling us.
And the iron by itself, that's kind of the iron that's kind of floating around in the body. Yeah.
So I will often see really weird stuff going on when you look at all of that in whole, you know. Sometimes I also look at the size of the red blood cells and the size of the white blood cells and stuff as well, just out of interest to see if they're big enough or too big or anyway, no, not a doctor. But this whole panel is so important. Like if I just get the ferritin, it could be fine. We probably need to mention that when you get an iron infusion, it's really only looking at upping the ferritin.
Yeah.
It's not going to it's not going to improve the Ubers, the taxis, the moving it around. It also, what I commonly see is there's this huge amount of ferritin uptake and there's a huge amount of drop off. So when my women get those kind of iron infusions, I love to prep them with antioxidants, you know, to buffer that oxidative stress because it is a heavy metal iron. And then I love to supplement them with our beautiful natural irons that also have what we call uroapothesis factors attached. So we traditionally always thought it was just, you know, have the orange juice with the iron, the vitamin C, but we now know it's so many other factors. So often I'll do the uroapothesis factors include like vitamin A and some B vitamins and other things, but also probiotics. And there's some really cool probiotics that we can now work with iron, and I can try and pull out the time that iron infusion is going to help someone rather than the...
But I think it's really interesting to know, because also just bringing it back to kind of basics for people, just while we're talking about this, that if you're supplementing with iron, it's going to take a few months.
Yeah.
It's not quick, right? And this is where often people will say to me, well, I've been supplementing for a while and I don't feel any better. And then I'll ask them and it's been a couple of weeks.
That's the same as vitamin D.
Totally.
So the things that get stored well, the aim is to get them up and keep them up and not supplement anymore.
Yep. Totally.
You know,
so the life
reason.
cycle of your red blood cells is 3 months. So it's going to take a few months before they're all fresh and new and happy. So it's going to take some time.
And how long have you been iron deficient? I think that's a really important factor too, because we're not going to be able to get it up in a few weeks if it's been chronically low.
And also just on that, while we're also talking about that, what we're also thinking about with our thinking caps is like why you're so low, right? So with iron, for example, is it, like we said, because you're bleeding excessively, or is there a real, malabsorption in your gut? If you're having chronic gut issues, potentially you can't absorb the iron like you should be. So you're supplementing, but nothing's happening.
Or you're eating all the right foods.
Yeah.
I so rarely find that the iron conversation ends up being about food.
Yeah.
Sure, if you're vegan, veggie, okay. Yeah. You're probably going to need a supplement.
Yeah.
If it's low. Because I see plenty of vegans and veggies eating enough and doing fine and all those things. But, you know, again, for me, I eat red meat.
Yeah, we sure do.
Sure do. I have antibodies against the parietal cells in my gut.
Oh,
so I have a really specific reason why I can't absorb iron. Yeah.
See, again, this is like such a naturopath thing to try and want to dig into and figure out what's going on. But like, the gut issues, you cannot like underestimate how powerful that will be in terms of impairing it. And also, just while we're also talking about it, we got to mention because I've seen this happen so many times in clinic where people have been supplementing with their iron with their breakfast and their coffee every morning. And so we know that coffee blocks the absorption of iron. So we know that if you're having it of a morning with your coffee, you're not going to get that beautiful iron.
Yeah.
Yeah. So I think, and we'll go into a lot more of that stuff, but I think it's just a really good example to talk about the iron.
Every single nutrient is like a different beast.
Yeah.
You know, so different parameters, different reference ranges. Some have really wide reference ranges. Some have really tight ones.
Yeah.
Ferritin is like generally 30 to 100. That's a massive range.
Yeah.
Like, do you want me to be 31 or 99?
Well, I definitely don't want you to be 31.
You see, you know what I mean?
Definitely not.
The other thing I think, like, do you have any idea where those reference ranges came from?
No. Do you?
Yeah, really interestingly. I was
tell
like,
me.
where do these reference ranges come from? So they're basically like based on sick people at the end of the day. So, you know, they take a huge amount of the population who've been getting testing, you know, who are probably more likely to be the sicker people getting more and more testing, and then they pull it all together and they make reference ranges. Every country has different reference ranges.
Well, also, so does every lab.
Every lab has different reference ranges.
Just going to put it out there. Yeah.
Yeah. So, like, if we look to the reference ranges in the healthiest, the people living the longest, those countries in the world, that is really cool.
Yeah, for sure. Yeah, it's just definitely a lot more complicated and a lot more like nuanced.
So if we get that vitamin D up,
Yep.
we get that iron up. I do want to mention, because there's always a flip side. I guess, like, the thing to remember is they can become toxic as well. So there's a point of supplementation, which we want to get you to a particular, you know, level, and then we stop. I've had to pull people off long-term vitamin D, you know, because they've been taking it forever. Yeah. And their vitamin D's through the roof.
Yeah, I know. I literally said that to a girl last week. She was like 156. I'm like, girlfriend, you're fine.
Yeah, please stop.
Cruise.
Yeah. You've done the job.
Yeah.
And, you know, like, that can be an issue. Yeah. So we've just got to be careful. The reference ranges are there for a reason. Yeah. But we use them to guide us, you know, with our clinical experience and with that patient symptom picture. So that's iron, that's vitamin D.
Or I really want to talk about prolactin.
Let's do it.
So prolactin is really interesting. And I think because, you know, we do so much in terms of fertility, I think prolactin is really important to talk about. So prolactin is produced by the pituitary, and generally the only time it's ever high is when you're breastfeeding. And that's why they say, kind of that old wives' tale of, you're not going to get pregnant while you're breastfeeding because your prolactin's really high.
It's not true. It's not true.
That's why I said it's an old wives' tale. Right, because your prolactin is really high. I would have been interested to see what your prolactin was during that time.
Yeah.
Your prolactin was probably right back down, just FYI.
Plenty of milk, but.
Yeah, interesting. All the herbs.
Yeah.
So when we talk about prolactin, right, I love to see prolactin with my fertility girls, especially if they've been trying for a while, because what I often see, so the reference range of prolactin is really interesting. And again, this comes back to the reference ranges. Depending on the lab, like we said, everyone's a little bit different. They'll usually say if you're under 400 to 600, it's normal, right? I personally, when we talk about optimal ranges, I love my girls to be in the 200s, right? Around there kind of thing. So when it starts getting that suboptimal kind of like higher level, my concern is, if this is high, is this potentially something that's making it harder for you to conceive? Now, we have great herbs in our clinic that can really help bring that down. With prolactin, when it's really high, so say 1500-ish, usually there's something benign leaning on the pituitary.
Yeah.
So if I ever do see a very high one, usually the doctor has flagged that, and usually they'll potentially go see an endocrinologist or something, and they'll investigate it further, right? But they've got good medications for that. I think, and this is my theory, this suboptimal prolactin, I just don't think it's been researched in women.
Yeah.
And so they don't know what to do with it. But when you look back in terms of what prolactin does, and when it should only ever be high is in breastfeeding women, it makes me kind of go, interesting. And again, person sitting in front of me. So if I have a beautiful woman sitting in front of me who's been trying to conceive for 12 months and it hasn't happened, then all of a sudden I see her prolactin, it's like 600. I'm like, oh, interesting. Let's do something to work on that.
There's a whole new phase of young women coming in with higher prolactin who maybe the first flag for them is actually that they're lactating.
Oh, yeah.
Yeah, so I've got, 22-year-old started, when she's in the shower, so the warmth, started lactating. And, when in pituitary's fine, her prolactin's only at 300.
Yeah, that's so interesting.
But she's lactating.
Yeah.
So even at a lower level, it can still be kind of wreaking havoc.
Yeah.
What I see in her is really hectic estrogen imbalance, you know, pretty bad endo, this weird prolactin thing, this lactation, you know, all the hormones are like seesaws. That's what we know. So that's why when that prolactin's up, you know, the other guys are pushed down, so fertility's low.
Yeah.
But it's not like that for everyone.
No. And again, like this comes back to like looking at the person in front of us and painting a picture of everything, right? Which is why, like when you come in with all the tests, we're going to bring it back to you and what's happening with you. What I do like and I do find interesting with pathology is looking at historical information. So I love when I have a few different numbers over a period of time so I can see trends.
Yeah.
You know, so I've seen some women where they have a trend in having some funny little liver markers, you know, but all of the women in their family, that's really common to have that. They've addressed it, you know, but even then with liver, we have stuff to help support the liver anyway.
Yeah.
But, you know, it's interesting to see a trend rather than all of a sudden this marker has just shot up out of nowhere. And again, that's even more interesting, more information.
Because in keeping with our theme, that could be completely normal for them, you know, for their whole life. I read something, I think it was their, I'm testing my brain now, but say it was their bilirubin or something. And she's like, no, that's always high. Yeah. My mum's is always high as well.
Yeah.
It's actually like got a name. Yeah. And it's like not to worry about.
Yeah.
Okay, cool. That's fine.
But even like, you know, if we just got to remember that, everybody's different. And also, like you're saying, like your set point is different. Yeah. Like I know, for example, my body temperature runs cooler. So I know if my temperature ever cracks 37, it's a fever. It needs to be 37.1, and I know that's a fever. Yeah. Because it never goes high. I'm always low. So again, we're bringing it back to that person.
Definitely. Do you want to talk about TSH? Really common kind of thing that we're looking at is thyroid. TSH is thyroid stimulating hormone. So within this kind of reference range chat, this is a big one.
Yeah. Firstly, I think with that number, it's always confusing with people.
Very confusing.
Right? So if your number on TSH is really low, it means your thyroid's going really fast. If the number's really high, it means your thyroid's going slow. It's kind of the best way to put it. Yeah. It's backwards.
It's one of those panels where we're seeing partial testing, you know, so TSH, thyroid stimulating hormone, nearly always tested. Yeah. You know, bada bing, bada boom. You know, it's Medicare covered, all good. Yeah. What we really want to see is the rest of the panel. There's TSH, reverse T3,
free T4.
Free T4, reverse T4, and then antibodies. And then the antibodies, which we have more of now, but two in particular that we want to see. So the thing about Medicare, you know, because we're in Australia, so Medicare's amazing. It covers a lot of our testing. Yeah. And testing's really expensive for the government. But the thing about that is if we were in a country where that wasn't covered, because you're paying, you get the full panel. Often you have to meet certain parameters to get certain testing, and the thyroid's a big one there because those antibodies do cost extra. Yeah. So if you have a family history, they're going to do it probably. If you have signs and symptoms, they're probably going to do it. However, with the thyroid, the symptoms are always very subtle and they take a really long time. So with all that said, TSH, what's your reference range?
It depends on the person. So if I'm wanting it for fertility, it's going to be tighter than, especially if someone's not been conceiving. Like I don't think I really want it above, 3?
I don't want it above 2.
Oh, you go tighter than that. So it depends on the person in front of me.
Yeah. I like it to be nice and low. And, you know, working with a lot of IVF, they also like
existent.
Yes.
The amount of women I've seen where their TSH is like 0.0 something. It's like barely even like negligible.
Yeah. Around the 2 mark. Yeah. You know, is really nice. If you're up at 3, don't stress. Like it's all good. They don't like you over 4.
Yes.
But I think for me, especially if they're going to do fertility treatment, I want it to be that bit lower.
Yeah. Yeah. So kind of under the 3. Yeah. Kind of at that 2 mark.
Yeah, let's say between 2 and 3. Yeah. And we'll both be happy. Yeah. But nowhere near 4.
So with thyroid, I think it's really interesting to talk about symptoms, right? Because then that can potentially give someone an idea of what's going on. Because again, we're sort of painting that picture for people. So when your thyroid number is really high, so we said it's going slow, So traditionally that kind of person is going to have, like, I think about it as your metabolism. So it means if you think about it in simplest terms, your metabolism is going slow.
Everything slows down.
Everything, right? So that's your digestion. So you're more constipated. You're cold because everything is going slowly. So the circulation isn't happening as fast. You put on weight. You struggle to lose weight. All of
brain
these
goes slow. Lots of brain fog.
Yeah, really slow markers. Yeah, if you just think about it, it's like we've turned the switch down in your metabolism right down slow.
Yeah, the battery power is very low.
Yeah.
The charge is low.
Then the flip side is if it's going really fast, everything's sped up, right? So they're hotter, for example. They run hotter. Everything's faster. They might get heart palpitations.
Yeah, really common.
Is a biggie. You know, so if you feel like you're like that all the time. With the slow one, it's often the people that say to me also, just thinking about it, like my feet are permanently cold, my hands are permanently cold, I'm permanently an icicle, right? So then again, same with when it's going really fast. They're the people that get really hot, really sweaty.
Flustered and anxious as well. Yeah.
And they're often slender, more slender as well, because everything just goes really fast. Yeah. So you can see how like either of these is not good.
Yes.
Right? You, like with your temperature, like with your heart rate, you want it to be nice and stable. And if that is your metabolism and it's going either one or the other, that's not good for you from a health point of view.
Your thyroid basically keeps you in homeostasis. That's the beautiful middle ground of health and where your body should be at naturally to have, you know, wellness. So that's why it is so important when we're doing fertility as well. Because if you're not if you're not balanced in homeostasis, it's going to be really hard for you to conceive. Yeah. Once you conceive, what I see with my thyroid girls is loss. And I don't want that for anyone. So if we can fix it before that, that's what we're going to do.
And it's definitely possible.
Yep.
Definitely possible. The other thing as well is that often in pregnancy, the thyroid will suddenly kind of go random.
Yes. Yeah. We expect that because of the hormonal surges.
Yeah.
And it's really hard for your body to keep in homeostasis when it's trying to keep another little human body in there in homeostasis as well.
Totally.
So there's a lot going on.
Yeah.
Often your thyroid will kind of stabilize after pregnancy if it does do that. Some women get thyroid disease purely, you know, during pregnancy.
Yeah.
Sometimes it hangs around and they get to keep that.
Yeah.
Unfortunately. The antibodies, you know, so you've talked about fast and slow. We've got hyper is the fast, the hypo is the slow. What the antibodies tell us, so that, you know, the first few tell us the functioning. What the antibodies will give us an idea about is what your immune system is doing in relation to your thyroid. Yeah. So the antibodies are basically telling us, like, is your immune system flagging your thyroid as a major issue and attacking it? Yeah. And that's what we really want to get onto early.
Definitely.
Because that's a very slow process. Your thyroid will fight a good fight, you know, because it's essential for so many things.
Yeah, so essential.
So it will hang on and fight for as long as it can. So this is one thing that we are looking for signs and symptoms of before pathology will even come up.
Yeah, absolutely. So, if we start seeing some wonky, weird things with your thyroid, we're going to want to jump on it.
Yeah, totally.
Absolutely. Anything we've missed?
B12?
Yeah.
I think B12 is really important because it's part of the B picture for pregnancy. So one of the things that we do, you know, for every pregnancy, for every woman is we really want them to be on a good prenatal. Yeah. And the reason is because of folate, which is B7. It's so important for prevention of neural tube defects. You and I like everyone to be on an activated pregnancy multi, which means all those Bs are ready to go in every woman that possible, you know. The difference between unactivated and activated is basically like it's pre-digested. It's ready to go. If you can't activate it in your own body for some reason, we've bypassed that. Bob's your uncle.
And I think, you know, again, coming back to the person sitting in front of us, like if you're vegan, the only source of B12 is from meat, right? So if you're vegan, you're probably going to have to supplement with B12.
Because bringing the B12 back in, all of these Bs into play. So we need them all to be good. We need no one to be high, no one to be low. I'm really careful with B12 supplementation. I don't know if you are, but I don't want to push all those other Bs out of whack.
No.
So I'm not just going to put in B12 because they're tired. There's a million reasons that they could be tired. Yeah. it does bother me that, you know, people are out there thinking if I grab B12 off the shelf, I'm tired, I might feel better. I think it's a bit more complicated than that, but B12 is really important for energy, really important for your nervous system, really important for pregnancy. Yes. So reference range?
Oh, I couldn't tell you off the top of my head. It depends on the lab.
I don't think it's a hard one.
No.
It does depend on the lab. We're just looking for it to be within that range. We're not looking for any nuances really there. We can test B2 and B6 now. We've been a little media about that being too high. I do like to test them if I can.
If we can, for sure.
If we can. And especially if they've been on a preconception for a really long time. So a lot of our women, the people we're seeing, they've been trying for a really long time. Sometimes I'll give them a break, you know.
Yeah, I do the same. Yeah, I think they're good.
Just might not need that much, you know. Because pregnancy multis are some of the best multis on the market.
Totally.
Whether you're pregnant or not. So we need to be really careful not to overdo it.
Yeah, I think that's really important.
So we're looking for pattern recognition. I love the, you know, you mentioned each one, you know, in the test panel. Sometimes I go, what happened in like October of 2020? She'll be like, oh, I had a baby. Great. Cool. That makes sense now. I got sick. Like, I love being able to do that and then work with the patterns. I see that you're historically really low in iron, but it's been really good for the last few months. Had an iron infusion. Yeah. Been working with a great naturopath, giving me the best iron ever. I'm not constipated. Works really well with my gut. I absorb it. It's come up. Great. Stick with that. If that's working for you. Yeah. So we're looking for, the pattern recognition. I maybe only worry when I start to see lots of things in that pathology going out of whack. Like you said, one or two, you know, if they're presenting well.
Yeah, and just questioning around it, right? Because, like, for example, right, I don't know how many times I've seen, you know, young, really fit girls in front of me, right? And their liver is all weird, looking funky.
Yeah.
And I say to them, you know, lots of liver enzymes out of whack. And I'll say to them, you go to the gym? And they'll be like, yep. I go, were you by any chance, did you go to the gym the day before you, or the day of when you got your blood test done? And they're like, oh yeah, I probably went the day before. I'm like, well, that's probably why your liver's out of whack, right? So that kind of high intensity training can temporarily make it appear as though your liver enzymes are out. But the reality is it's just the impact of that training. Then it goes back down again. Because like we said, so much of your body is dynamic.
Absolutely. No matter what we're testing, like we talk a lot about this with hormones. So, you know, our hormonal panels, they can be fairly unuseful if they're just a random day. Yeah. We have the days that we like, you know, which we can talk about. But that timing does kind of matter, you know, with a lot of other tests. We want to make sure that, you know, we're getting the right or the most right, you know, most correct result that we can with that timing. Yeah. So let yourself just chill with the gym, get a good measure on that. But with the hormone paneling, I like day 3, but only because I then like to compare it to 7 days post-ovulation. This is a big one because day 21 is not 7 days post everyone's ovulation.
No.
So this is something I'm explaining to a lot of my patients. I really want to see both. Yeah. One or the other, not so helpful. Maybe the 7 days post is more helpful than day 3. Yeah. But I really want to see that 2 points. We call it a 2-point panel. There's now an 11-point panel.
Wow.
Yeah.
Fabulous. Right.
But that's a lot for someone to do.
That's a lot of tests.
That's literally in your period of, like in your menstrual cycle, the entire cycle of, say, 30 days, let's just say. You've got to go and get 11 blood tests. Amazing information for me. But also, that's just that one cycle. So a couple of mistakes my women are making, they're always on day 21. They could have a 21-day cycle.
So a 23-day cycle.
Yeah, so could have ovulated much earlier. It's too late. Yeah. Could be the other way around. Ovulated later, it's too close. Also, the mistake that I'm commonly kind of seeing with this is that they get when I see them, it's like day 15. So they get the day 21 21 days, 7 days post, and then they go get day 3 the next one. And I'm like, no, can we just try and keep it in the same cycle?
Oh, yeah.
Yeah, like a split.
Yes.
So we want it to be, each one's going to be like unique, right? Same cycle, day 3, 7 days post ovulation, ideally.
Yeah, I think that's definitely an important point to make, that it should be within the same cycle if you are going to do the 2 points. Yeah, no, that's a really important point to make.
Please.
Yeah, absolutely. Just like, I can see there being benefit, but there's also so many problems with it. But this is where, like, we come back to looking at other stuff like your wearables, for example. We look at the tracking stuff that you're doing. We want to see your temperature. We want to take that into consideration when we're looking at that information.
Yeah, absolutely.
Yeah.
The pathology isolated is not overly helpful. If I just get a 42-page document and I've never met that person,
Yeah.
it's not overly helpful.
Yeah.
And, you know, it depends on your goals too. Like we said, there's different things that we look for if you're trying to conceive. Maybe you want to run a marathon, you know, like maybe you want to, I don't know, go climb a mountain or be Ironman or do something amazing like that. Or maybe you just want to avoid a disease that runs in your family. Like there's those kind of things as well. So what are you seeing in clinic right now?
What am I seeing? So definitely the prolactin recently. Definitely.
Yeah.
I've seen that a couple of times recently. I am often looking at it, especially if someone hasn't been having a regular period.
Yeah.
Because I do believe that that is potentially impacting why you're not having a regular period, right? Coming back to explaining, you know, what we said about how prolactin works.
Yeah.
So I've found that really interesting that I've been seeing recently. And again, we work with you. We have specific herbs that we give you when we're in clinic, and we can make a big difference in that.
Yeah.
So I think the prolactin is something that I'm seeing a lot recently. What about you?
Yeah, the younger girls with the prolactin. I had one just a few weeks ago who actually did have, excuse me, something pressing on her pituitary. Can get operated on or can take a medicine.
Yeah.
So they're just trying to weigh that up because that medicine can't be taken while you're trying to conceive. So we're going to do the medicine.
Yeah.
Get it, hopefully shrink that, you know, whatever it is. Get that pituitary, you know, get the pressure off the pituitary. And then hopefully that prolactin will come down. She'll stop lactating till she needs to.
But I had the same thing.
try and
You know, I
conceive.
had the same thing. It was a while ago now, but one of my fertility couples, they weren't conceiving, and I was like, I just really want to see a prolactin. I'm just digging a bit deeper. And yeah, hers was 1,500, 1,600.
Wow.
And her doctor was like, whoa. And we were like, whoa. So she got it scanned. Turns out she did have that what do they call it?
Prolactinemia?
Yeah, prolactinemia. So there was that growth that was leaning on the pituitary. So instead of they went the medication path with her. The medication shrunk it, and then she fell pregnant.
Oh, yay.
Yeah.
Yeah, that's beautiful.
Yeah.
I have had one patient get the surgery. Really successful.
Yeah, great.
Hers was a little more serious. I can't remember
Yeah.
exactly, but yeah, she got
Yeah.
the surgery. And
I've had a couple have the medication, and it's worked really well.
Yep.
And then also, I've had that suboptimal level, and herbs have brought it down
yeah, that's cool.
really successful.
Yeah,
You know, and it's great to be able to have that as an option for people.
absolutely.
Yeah.
The other things that I'm seeing really commonly is something that you mentioned, men with lower vitamin levels. So I don't think that our men are getting tested enough for this.
Yeah.
With women, we seem to run fairly good panels. We do the TSH, we do the vitamin D, we do the iron, especially because we're bleeding. But for our men, yeah, we don't do them as commonly. So low zinc, low iron. I've picked up a few really high seleniums.
Ooh. Yeah.
So selenium is a nutrient that can be quite toxic to the sperm if it's too high.
Yeah.
And it's needed for sure.
You need
but
it
when
like
it's too high,
Goldilocks range
yeah,
with it.
yeah,
Yeah. Yeah.
it's eating the fish from where I'm from. Like, so we live around a big lake. It's had a big smelter on it for like ever, and people who eat a lot of fish, my men, fishermen, runs in the family. So this is
that's so
a toxin, you know, in this level it can be passed on as well. Yeah, so I'm a bit obsessed with high selenium at the moment. So, just check all my men. But we want to make sure that zinc is there, if they're trying to conceive for that sperm tail. I do also chronically see that iron panel only coming out at ferritin.
Yeah.
Which is not overly helpful. So I do often ask them to go back and get the full panel.
Yeah.
Which I find really helpful because then I know a little bit more. The other thing I'm seeing a lot of is the thyroid stuff.
Yeah.
So getting that thyroid back into range, I like to, if it's hypo, use the nutrients that the thyroid loves to chew up. So like give it extra fuel and then try and, because I think for me, I picture it as like if it's working really slow, it just doesn't have enough
food.
Yeah, it doesn't have enough petrol in the tank. It's like I'm trying to get there.
Yeah.
So we use tyrosine, beautiful amino acid. I like to give it some B vitamins, a little bit of iodine, all those kind of things. And we can test a lot of those too. But I figure let's just put some in and see how that goes.
Yeah.
Not forever.
Yeah.
But yeah.
And they generally start feeling a lot better.
They do.
They're really
yes.
sensitive to how that, the effect of that. I find they feel better quite quickly with that, which is awesome.
Yeah.
And again, we're trying not to go down the, medication path if we don't need to.
Yeah, exactly. Because once, there's some things we need medication for, like the pituitary thing in isolation. Let's sort it out. Let's get that done. But with thyroid meds, it's a little more complicated. It's often a long term. Once we start that, and we want to try and pull out the longevity of your thyroid as long as we can. Yeah. Given that it's already flagging, that
we
it's
just want to help your body to do what it's supposed to do itself.
Yeah.
Yeah.
So to finish, we know now a normal blood test does not automatically mean a healthy person.
Yep.
Healthy person does not automatically mean that you're going to have wonderful blood test results. We don't use our pathology in isolation.
No.
We use the person. Any other takeaways for you?
I think it's the patterns. The patterns is really important, and looking at also other particular potential pathology markers as a whole person as well. Yeah. So not just kind of going, oh, you're one iron thing and that's what we're going to hone in on. We're looking for other clues, like Mel was saying, other iron, different markers together. Rather than just that ferritin, and trying to dig a bit deeper and get a bit of a better understanding, but bring it back to your symptoms and what your health goals are as well.
Definitely.
Yeah.
I think that this one's going to be really helpful. I hope you guys love it. Thanks for listening in. We hope you got something out of it, and hit us up with any questions or feedback, and we will see you again soon.
Thanks, guys.